Ruben de Winter, Mike Gibson coming to you live from TCT 2025, and we're talking about the PROCTOR study comparing native vessel PCI to saphenous vein graft PCI after CABG. Ruben, tell us what you did and what you found.
Thank you, Professor Gibson, for the introduction. And first of all, I would like to say I'm honored to be able to discuss the first result of the PROCTOR trial today here with you, and naturally on behalf of the PROCTOR trial investigators. Well, I think the PROCTOR trial is about some of the key challenges that we face in managing post-CABG patients. We know that long-term efficacy of bypass graft surgery is limited by both bypass graft failure and progression of disease in the native coronary arteries. And as a result, there's a substantial number of patients that present with recurrent angina symptoms and ischemia, affecting up to 6 out of 10 patients at 15 years after bypass surgery. And many of these patients return to the cath lab for repeat coronary angiography and further revascularization therapy. And this is a patient population that is high risk and complex because patients are typically older, more frail. They have a high prevalence of risk factors and comorbidities, as well as complex and more advanced coronary lesion morphology, which is driven by, on the one hand, diseased bypass grafts with friable plaques, predominantly degenerated saphenous vein grafts, and on the other hand, extensive but also accelerated disease in the native coronary arteries, resulting in long and calcified lesions and a high prevalence of chronic total coronary occlusions, which is reported in over 50% of these patients. And if patients with a previous CABG require repeat revascularization, current guidelines recommend PCI of the native coronary artery over PCI of the diseased bypass graft with a class 2A level of evidence B, which is based entirely on observational data. And there has been no randomized trial comparing native vessel PCI with bypass graft PCI. And that's why we set out to do the PROCTOR trial, which is the first randomized study comparing a strategy of native vessel PCI with saphenous vein graft PCI in patients with prior CABG who present with bypass graft failure and a indication for repeat percutaneous revascularization as determined by the heart team.
And what did you find?
We randomized 220 patients in total, 108 in the native vessel PCI group and 112 in the SVG PCI group. And the primary endpoint for this analysis was MACE, so major adverse cardiovascular events. And that was a composite of all-cause mortality, non-fatal target coronary territory myocardial infarction, and clinically driven target coronary territory revascularization. And we found, and we present the 1-year results at the TCT this year, we found that MACE occurred in 34% of the native vessel PCI group compared to only 19% in the SVG PCI group, which resulted in a hazard ratio of 2.14. 95% confidence interval between 1.25 and 3.65, so more than twofold higher risk of MACE following native vessel PCI compared to SVG PCI group at 1 year.
Wow. So you ask an honest question, do an honest trial, get an honest answer. Were you surprised by the results?
Yeah, I can't say we were not surprised. I mean, there has been a lot of observational studies that have consistently shown lower rates of MACE following native vessel PCI. The largest one, perhaps, the study by Professor Brilakis and colleagues, a VA study of more than 10,000 patients that showed lower rates of major adverse events following native vessel PCI compared to bypass graft PCI. But all observational data. So this was the first randomized trial in which we have to say both strategies had to be technically feasible, considered by the heart team. But it was a surprising outcome at 1 year. Yeah, it was a surprising outcome. And if you look at the components of MACE, there was no significant difference in all-cause mortality, which was 6% in the native group and 4 in the bypass graft PCI group. But we did found a significant difference in the occurrence of non-fatal myocardial infarction, which occurred more frequently in the native vessel PCI group compared to the bypass graft PCI group. And this was primarily driven by a difference in PCI-related MI, which was 13% in the native group compared to only 1% in the bypass graft PCI group. So the low rate of PCI-related MI in the bypass graft group was kind of surprising.
Yeah,
Only
that's very
1%,
surprising.
whereas in
I would have thought it'd go the other way around, with a lot of
yeah,
heavy disease
that's
in the
not a
major.
lot in observational studies.
Yeah. Well,
Yeah,
look,
yeah,
this is
yeah.
why we
And
do
we
randomized
know from
trials.
observational data that there's a high risk of exactly, exactly. And of course, we suspected the risk of no reflow, distal embolization. But on the other hand, the native vessel PCI group was a really complex cohort with 80% of the patients in the native vessel PCI group who had a chronic total coronary occlusion. And those were really complex procedures going RDR through the vein graft. So complex procedures, and we had really skilled operators, but still, there was a higher risk of PCI-related MI in that group compared to the bypass graft group. But what we also found was that there was a higher occurrence of repeat revascularization of the target coronary territory in the native vessel PCI group with a hazard ratio of 2.19 at 1 year. And of course, this is only the 1 year study. We know that Sevenous vein graft disease tends to progress aggressively after stenting with high rates of restenosis, stent thrombosis. So we have to await the longer term follow-up to see if the clinical advantage that we have now seen with Sevenous vein graft PCI will maintain over time. But at 1 year, SVG PCI was associated with better outcomes.
Wow, tough study to do. Well done. Congratulations, Ruben, and to you and all your investigators. You asked an honest question, changed how we viewed things. Thanks for joining us today, and thanks to all of you for joining us here live from TCT 2025.